Now, it is my pleasure to introduce to you Dr. Christine Corbett Dmp, CNNP, Fellow of the NKF. She is an Associate Chief Nursing Officer for the Advanced Practice Providers and a practicing nurse practitioner in nephrology and palliative care at Truman Medical Centers, University Health, Kansas City, Missouri. Dr. Corbett has practiced in the field of nephrology for over 23 years and palliative care for over 1 year. Dr. Corbett's doctoral focus in 2018 was shared decision-making, advanced care planning, and appropriate palliative care referral for chronic kidney disease patients. In the past 2 years, she's developed, implemented, and currently manages a conservative kidney care clinic at TMC UH for patients who choose not to pursue dialysis. Her clinical passion lies within conservative kidney care, prioritizing quality of life and patients' wishes through continued supportive care. Additionally, she enjoys sharing the vision of conservative care with her nephrology colleagues. She is involved and engaged in the Coalition of Supportive Care of Kidney Patients and Their Pathways program, the Hospice and Palliative Care Nurses Association, the American Nephrology Nurses Association, and serves as the National Kidney Foundation Medical Advisory Board member, fellow Renal Roundtable Committee member, the 2019 to 21 Executive Council for Advanced Practitioners, and NKF Health Equity Committee member. Please join me in welcoming Dr. Christine Corbett.
Good morning, everyone. I'm so excited you're all here. It's a beautiful day outside, sunny Florida and the beach, so I appreciate you being here with me this morning. This is a passion of mine, and we're going to walk through my journey and also the journey of a patient case as we walk through medical management without dialysis. I have no financial relationships to disclose. We have a pretty hefty overview of objectives today, including defining active medical management without dialysis, looking at research and initiatives, barriers and facilitators to programs, tools and prognostic indicators, palliative care, and then obviously optimizing patient-centered care through shared decision-making. So we're going to start with a case study. This is an 81-year-old patient with kidney disease stage 5, has been seen in the clinic for years. This patient was referred to me for kidney disease education due to refusing dialysis and refusing dialysis access. Does this resonate with anybody? Have you had those conversations? Nephrologists often refer them to you. Yes. So patient's past medical history, CKD stage 5 for years with an estimated GFR of 14 cc's per minute, hypertension, anemia, receiving ESAs monthly, history of a cerebral vascular accident, wheelchair bound, coronary artery disease, and congestive heart failure, for which this patient had been admitted several times during the last year. Social history, widowed, lives with his son, who is the primary caregiver. So in our assessment and plan, CKD stage 5, we're going to talk about treatment options. What options are we talking about? All the options, transplants off the list, right? Because the patient is 81 and most transplant facilities don't transplant over 70. Dialysis, home dialysis. Okay, we're gonna walk through this. So my journey started, as Beth mentioned in my bio, years ago when I was working on my doctorate degree. So anybody interested in a doctorate degree or have already pursued one? Okay, so I've heard two versions of what you do when you're looking at a project. One is you pick something that's simple that you can get done so you can get through your program so you can get your degree, right? Have you probably heard that too? The other is, and my mentor mentioned this, and I'll shout out her name, Dr. Susan Kimball, Molly knows her actually. She said, pick something that you're passionate about because you're going to spend a few years on this project and then beyond, potentially. So this is my project. It was involving 2 Kansas City area nephrology practices and looking at those providers, nephrologists, nurse practitioners, and nurses who were who were seeing CKD patients in the clinic, but also understanding their awareness of the guidelines, shared decision-making, and the appropriate initiation of and withdrawal from dialysis, as well as appropriate palliative care and advanced care planning. So the results of that was post-intervention, we had over 21 advanced care plans completed between the 2 organizations in a 4-month time period. And we also had 4 palliative care referrals in 4 months, just with awareness of the guidelines. So that took me to then writing it up, right? So I'm talking about this for nephrology nurses in general, because if you do a project, you really want to publish it. So this was published in the Nephrology Nursing Journal a couple of years ago, 2018. So we'll talk about really what do patients want. Sarah Davison and colleagues did an end-of-life care preferences study in 2010 and found that there were over 584 patients that were surveyed who had CKD stage 4 and 5 as they presented to dialysis or transplant. And as you can see here, I've kind of blown up some of the areas. 90% of those patients want prognostic information from their nephrology team for an informed decision. 84% want their symptoms managed by nephrology, and I know many of us manage those symptoms, COPD exacerbations, CHF exacerbations in the dialysis unit, right? It's like, big span of scope there. 61 of dialysis patients had dialysis regret. 61% of the patients who started dialysis in this study in 2010 had dialysis regret. And less than 10% of the patients received end-of-life discussion by their nephrologist. So nobody talked to them about what was next steps. And that meant that 10% of the patients at the top of the list here did receive prognostic information. The rest of the 90% did not. So let's introduce active medical management without dialysis. I'm going to start with the it is not. It is not doing nothing. It is not saying, oh, I'm sorry, there's nothing else for us to do if you don't want to pursue dialysis. It is not referring the patients back to primary care and signing off on them. Have you seen that happen in your practice? I did too. It is not lack of support. It is not giving up, because it is active medical management without dialysis. So it is holistic, person-centered care. It is conservative and supportive, which are other terms used for the same thing. It is also comprehensive. It's active, supportive of patient preferences, wishes, and values. And then it is for persons who forego dialysis or for whom dialysis is not indicated, and we'll talk about those indications as we walk through this. Again, defined, supportive conservative care is an alternative to dialysis. It is management of kidney disease. It is still focusing on slowing progression with the overall goal to improve quality of life. It is through communication and shared decision-making and advanced care planning, looking at patient and family preferences and values and prognosis. Family included in this discussion. It is symptom management, managing symptom burden associated with CKD and end-stage kidney disease. And we know that the research indicates that symptoms are not always addressed or are under-addressed or not recognized, despite studies indicating that patients with CKD and end-stage renal disease or kidney disease may suffer more symptoms than those with cancer receiving chemotherapy. It may be more beneficial for certain patients than dialysis. And we'll talk through this again here in future slides, but if a patient has a terminal illness other than end-stage kidney disease, if they're over 75 with comorbidities, if you answer no to the surprise question, anybody familiar with the surprise question? Excellent. If you answer no to the surprise question, the 6-month or the 12-month, it's up to you, whichever one you want to choose. If they have a functional impairment, so our case study patient, she was had a stroke already and was in a wheelchair, and so her functional status is a little bit lower. He would have mentioned that he had a great quality of life despite the comorbidities, but definitely did not want dialysis. And it's important to incorporate assessment tools, and we'll talk about those, depression screening, quality of life assessments, and then use some resources to help support those patients to be chosen for conservative care. So we have current initiatives and research ongoing. I had just mentioned that Dr. Alvin Moss has been a pioneer in conservative kidney care. He helped develop the Coalition for Supportive Care of Kidney Patients. He also authored this palliative care and nephrology text that just came out last year. It's an amazing resource. I use it often. There's also, KDIGO has the 2016 Executive Summary of Controversies, discusses a roadmap to improve quality of life for kidney patients, which also includes active medical management without dialysis. And in the center there, the Alberta, Canada group, Dr. Sarah Davison, as I mentioned earlier with her study in 2010, developed the CKM Care program also. So great resources here if you're interested in this. Kidney Health Australia is another program with over 300 patients enrolled in conservative care. And again, with the palliative care and nephrology, this is Dr. Alvin Moss, Lupu, and Lou Diamond with Nancy Armistead, who is a nurse, a nephrology nurse, who helped co-author this. So looking at the Pathways Project and the Pathways Project Change Package, which are through the Coalition for Supportive Care of Kidney Patients, and just a hands up, anybody heard of the Coalition before, utilized resources? Okay, they have a lot of great resources out there. So the Pathways Project implemented evidence-based practice into 15 change agent dialysis and kidney disease CKD centers. The team educated center staff on seriously ill patient identification, conducting goals of care conversations, using the ask, tell, ask approach, and transitioning patients at the end of life to palliative or hospice care or palliative dialysis. The pathways increased both identification of and goals of care for seriously ill patients in dialysis units. They also increased advanced care planning in units in CKD centers. So we're looking at phase 3 with the Pathways program. I had been involved in the phase 2 piece several years ago. We had to wrap things up during the pandemic, which was interesting, but the next phase is recruiting for active medical management without dialysis program development in kidney disease centers. So if you have CKD centers, if you have any interest in looking into that further, please let me know. My email will be at the end. And so this is kind of their change package in a nutshell. So it's supportive care capacity, creating the system. It's values-guided care, which means respecting patient values and preferences. So you have to talk to the patients, right, to get their values and their preferences. And it's just right care. It's the right care to the right person at the right time. And then, of course, it's through the continuum. So we're not going to just sign off at the end. Once we refer patients to palliative care or hospice care, we will continue to enhance support at the end of life. Here's some additional research that's been out. This was a study or an article that was written in the New York Times in 2019. The so-called conservative management can ease symptoms without dialysis in some people with kidney disease, but many of them are never given the option. So we know there are a lot of resources out there for patients to discuss kidney transplant when they are nearing end stage, right, or at least CKD stage 4 or 5. Kidney transplant, home dialysis, peritoneal dialysis. Are you all including conservative management in your education as well? Excellent. I love the heads nodding. So perfect. The research has shown that many nephrologists are not including this piece in their education. So this is looking at those seriously ill patients again, aging populations, and then focusing on quality of life. You'll hear me repeat the same things throughout the research here quite often, but This is really a case discussion about a patient who required dialysis for many years. He was kidney transplanted twice, then decided to forego dialysis for a better quality of life.